having classes to teach. A little bit about myself and who is this guy and why is he up here and he was just a med too. I then went on and got my critical care paramedic soon after that in 2009. I got that finished in 2010. After that, I went and got my instructor certification, and I'm an American Heart Association instructor for CPR, ACLS, and then pediatric advanced life support. Above that, I worked for the equipment clinic on critical care transport. I became an instructor with Youngstown State University back home in Ohio, teaching in the Department of Health Professions, nurses, and paramedics. And then I went really quick on what is the patient, how is the patient presenting, what's going on with the EKG, and then not only knowing how to treat the patient, but how the patient can respond. So Kyle and I were talking, and this is why we decided let's do a little bit of EKG for this peer-to-peer, and if you guys have any questions, hopefully I can answer that. And if anybody's had any experience with EKG, please let me know, okay? And then we'll talk about it. I know these people over here have not had any experience with EKGs, but anybody over here? No? You guys have never read an EKG or performed one or anything like that? Okay. No, but at least you have the idea. At least you have the idea, right? More than just some squiggles on a piece of paper. So, what we're going to do is I'm going to take you through a little, maybe physiology of the heart, and real quick, and we're just going to go over maybe a basic concept. This is my cartoon drawing of the heart. Okay. Obviously, this is the right ventricle, the right atrium. Sorry, this is the right ventricle. All right. So up in here, this is the primary pacemaker of the heart. Does anybody know what it's called? SA node. That's the SA node, right? And the SA node, you know how many beats per minute that's supposed to conduct the signal from the SA node to the bottom of the heart? There's a range, but if you give me the average, what's a normal resting heart rate? How about that?
60 to 100.
60 to 100, exactly. So the SA node is supposed to conduct at a rate between 60 to 100. Okay? Now, this is the primary pacemaker of the heart. What happens is you have these infranodal pathways that this electrical impulse comes down from the SA node and it brings it to the structure called the AV node. By definition, the AV node is just supposed to slow that impulse down by 5/100ths of a second. So it's coming down from the SA node, coming down, and it's landing right here, and then that AV node is going to slow down the impulse by 5/100ths of a second. Now, in the event that the SA node quits working, either because of right coronary artery occlusion or because of old age, the AV node will kick in as your secondary pacemaker and try to allow you to survive until you get an intervention. Does anybody know the impulse rate of the AV node? No? The AV node has the intrinsic ability to fire between 40 to 60 beats per minute. Okay? And as we go down to the heart, the amount of intrinsic ability to fire decreases. So what's going to happen is you're going to go from the SA node down the infranodal pathways to the AV node. Right? Then you're going to come down from the AV node to the bundle of His. Right? And then you're going to come around the ventricles to these fibers down here. And these fibers down here, those are known as the Purkinje fibers. They take the impulse from the SA node as it travels down and go to the ventricles and stimulate them to contract. If the SA node fails and the AV node fails, then the Purkinje fibers will allow you to have a last-ditch effort naturally until you can get to emergency care. The Purkinje fibers will fire at a rate, we want to take a guess? 20 to 40, very good. 20 to 40, all right? So once you get down here, the EKG changes. You'll be able to see that on the EKG. We're not going to get that depth into today, and today what we're going to talk about is a normal EKG and anything that involves the SA node to make the EKG a little bit different. So SA node 60 to 100, AV node 40 to 60, Purkinje fibers 20 to 40. And this is what we talked about in that. This is a more representative picture of that, but you can see that you've got the SA node, the AV node, the infranodal pathways, the bundle of His, and Purkinje fibers that go out like that. All right, so with this is just showing you the polarization of the heart as it travels down from the SA node. Electricity, we'll start at the top. You get your SA node polarized, and that's going to happen here. And then the impulse is going to go down to the infranodal pathways here, as we talked about. Depolarization spreads slower. Why? Because the AV node slows down the impulse by how far? How much? 5/100ths of a second, right? 0.05 seconds. All right? Then that allows the ventricles, in case they weren't completely repolarized, it gives that time for ventricles to kind of relax, fill up with blood. Then it comes down through the bundle branch here and then spreads out across the ventricles. And that is pretty much how the EKG, we take this and we put it into a picture that we can see. So here's your picture. From the SA node all the way to Purkinje fibers, it makes this drawing here. And this is representative of a normal EKG, if you will. The atrial depolarization is the P wave. Okay? Your Qrs complex is for ventricular depolarization, right here. Right? And then your ventricular repolarization is going to be your T wave. Now, when we talk about the Qrs complex, this here is your R wave. And that R wave is going to be important when we start to talk about how fast the heart is actually beating. All right. So when we go to EKG measurement, we're going to go R to R intervals. So just remember that the R is the first upwards flexion in the Qrs complex. All right. First upward flexion in the Qrs complex. Okay. So. Well, I already told you that what the heart does, it paints a picture. And so when we do this, we hook somebody up with what's called an EKG machine. And the EKG machine will sense the electrical activity of the heart and actually paint that picture that we just saw. The EKG machine, what it's going to tell us is how often the heart is beating or how often that it's depolarizing, what the depolarization is, where the impulse is coming from. Is it coming from the SA node? Is it coming from the AV node? Or is it coming from the Purkinje fibers, depending on if they have ischemia, or if they're having a heart attack, or what condition the heart's in. We can also look, and we can see by that, a patient may have what's called ischemia. Ischemia is hypoxia, so you have lack of oxygen. Very good, guys. Come on. So if this is normal, okay, we can actually tell just by the T wave, we can tell if the patient is hypoxic or if they already had some sort of cardiac activity that went on. Because what's going to happen is this T wave is going to be inverted. So an inverted T wave will show hypoxia or a little bit of ischemia. All right? And again, just to recap, this is the P wave. The P comes from the SA node, Qrs, all right, and this is the T wave. So there's a lot that we can learn from the heart. We're not going to go all the way into that, but we can see if they have ischemia. We can see where impulse is coming from, the P, the Qrs, or if it's coming from the Purkinje fiber. If the P wave is taken out, okay, what's going to happen is you're going to have a line. And where the P wave should be, it's not going to be there. So that means that the AV node is taken over. So what happens to the Qrs, it's supposed to be narrow. The Qrs will actually be a little bit wide. I'm exaggerating this, and then you'll still have a T wave. So from here, I know that I don't have a P wave. So what's not working? What node? The SA node is not working, right? And I know that my Qrs has widened a little bit, so I know that I'm probably coming from the AV node somewhere. So again, P wave, SA node. No P wave, the SA node is completely knocked out. Does that make sense? Okay, great. All right, so when you hook somebody up to an EKG machine, you have what's called a lead, and a lead is the view between two wires, or two stickers, if you will. An electrode, if anybody's ever had an EKG done or you performed it, those are just the foam pads that go on your body. And so what a lead is a one view looking between those two stickers, or those two electrodes. On a normal EKG machine, without getting into a 12 lead or something more complex, we use leads 1, 2, and 3. And what that's going to give us is that's actually going to give us a couple different views of the heart. So when we connect the leads to the patient, all right, you'll see this RL here, this right leg lead. It's optional. Some EKG machines don't even have it. It usually just acts as the ground. But what you want to have is your white, your black, and your red. And so that stands for right arm, left leg, and right leg. So what happens here is between these, you get this field. And this field, it's called a triangle. This is called the Einstein's triangle. And what happens is your leads have positive and negative, So what happens when I hook these up, I'm actually looking at the heart this way, and I'm looking at the heart this way, and I'm looking at the heart this way. All right? Now, okay. So I'm able to see 3 different views of the heart. Since this responds to lead 1, 2, and 3, we'll see that in a second. From the center of that triangle, I can actually get other views. I can do what's called an AV-F, AVR, and an AVL, which just makes it up. So not only do I get my leads 1, 2, and 3, I also get 3 other views of this heart based on this iron instrument. All right, and this is kind of what I think get this mixed up. This is kind of what happens. So it goes from negative to positive. Look at the heart this way. Look at the heart down, down, and then I can get 3 other views from the center of this triangle that go backwards in electronegativity. So when we hook a patient up to a more in-depth EKG, we have 6 around the left side of the thorax. And we're able to see actually 12 different views in combination with our lumens. So lead 1 will represent one part of the EKG. Lead 2 will show another one. Lead 3 will show a third one. And then going outwards, you'll have 3 other ones. And if you notice, each one of these EKG complexes are slightly different. And that's because of the way it's looking at the heart. Does that make sense? So you combine all those. This is the same patient at the same time. Lead 1, 2, and 3. So if I have something that I don't see that's maybe quite right, and I'm like, well, what is this? Is this a P wave? I can compare 3 different views of the heart at one time. I can see, look, this P wave is present in all of these leads. Does that make sense? So now I can just switch the monitor on the EKG interpretation. I can see, yep, they all look the same. There's a P in every lead, so I kind of know that it's coming from PSA. So again, just give you different views of the heart so you can see what's going on. This is a representation of a normal EKG complex. And this is what wave? The P. This is your Qrs complex, and this is your T. All right? So this here would be what's called a normal sinus rhythm. Sinus because it comes from the P wave, and rhythm because it's regular all the way throughout. So normal sinus rhythm. We're going to get into how to identify these here in a little bit. When we talk about the graph paper, what we're talking about is little boxes here. Okay, and then you take this box and you zoom it in. You'll have 5 boxes across. Each box is 0.04 seconds. And you take that across and you have 0.20 seconds. So what happens is we're actually able to diagnose where things are happening if the patient has a heart block just by how long a part of that EKG is. We're able to tell that if there's a bundle branch block coming down from the AV node, we're able to tell that if the Qrs complex is greater than 3 little boxes, that he's got something going on with his AV node. And we're going to get into that in a little bit. But this paper, and it's similar for every EKG machine that you will ever work with, is the same. All right, when you go vertically, it talks about millivolts. However tall that Qrs complex is, you can actually start to look and see, does the patient have what's called hypertrophy? It's a left side of hypertrophy, right side of hypertrophy. But that's for a whole different class. All right? But this, we're just going to focus on the horizontal components, and we're going to measure intervals, like the P wave, the Qrs complex. And then there's going to be one thing we look about the millivolt, and I was telling Arbor, and that's the ST segment. And from the ST segment, you can actually start to diagnose a heart attack. Here's just another view of that. So, some EKG papers have these slashes on top. And between the slashes, that represents 6 seconds. So if I had a bunch of different Qrs complexes in here, what I would do, what I would do is I would count 1, 2, 3, 4. There's 4 complexes in 6 seconds. How many seconds per minute? There's 60, so I'd multiply that by 10, and I'd have a heart rate of 40 or so. All right? But most EKG strip paper do not have those slashes. So I'm going to teach you how to compute the R interval or the heart rate for that. All right, we've already went through this. The P wave is the polarization of the left and right atria. We know that it's smooth and it's upright. The PR interval is the time that it takes for the impulse to get from the SA node down to the ventricle. The Qrs complex is coming down even more. so that when the EKG gets down to the ventricle, it shows how long it takes to get there. Let me go up a little bit. We talked about that time interval. The PR interval, all right, is the time that it starts from the P wave until the start of the QRS. So when I measure this PR interval, I'm going to start here, and I'm going to count the amount of boxes this way until my QRS complex starts. If that's greater than 5 boxes, if that PR interval is greater than 0.20 seconds, I know that I have a first degree heart block. So I can tell that there's something going on maybe right there. So I don't know exactly what it is, but I know that it's taking a little bit longer amount of time for it to get to where it needs to go. Does that make sense based on the measurement horizontal? All right, now I know what everybody told all the professors were like. The QRS complex. The QRS complex, all right, I had just mentioned this a few minutes ago that if it gets wider, then that means the stimulation is coming from somewhere else, or that the stimulation that actually blocked maybe here. So it's either coming from the AV node or it's blocked somewhere down here. So this should be less than 3 boxes. Okay. So the PR interval should be less than 5. The QRS should be less than 3, and that corresponds to those times. Does that make sense to you guys? The ST segment. The ST segment is when the ventricles start to repolarize, and it's the resting phase. So the heart's really not doing anything. It's waiting to relax and get another stimulant. Now, you put those all together, this is what it looks like. You have your P to QRS T segment, and that's what you will look like. This line here is called the isoelectric line. When we start to look and talk about EKG, everything should start and end on this line. So the P wave should start on that line, and the T wave should end on that line. Any deviation of that line means that there's something going on. It could be electrolyte imbalance, or in the event that they're having an ST elevation, a STEMI, what's going to happen is you're going to have, start on this line, right? But instead of this here, that's ST elevation. So when somebody says, oh, they're having an ST segment or a STEMI, ST to STEMI, that means that the ST segment is elevated, and there's already injury going on in that specific part of the heart. Okay, so this is really the only time that we're going to talk about the millivolts. So all it takes is really 2 millivolts, which is 2 millimeters of that off the isoelectric line to actually activate the cath lab and get a patient in to get cardiac therapy. So whether that's open heart, whether that's bypass, whether it's going in and just putting a stent in, all it takes is 2 boxes higher than normal and 2 or more leads. Okay, so we can learn a lot off this EKG machine just by already, without looking at different views of the heart. This is just one view of the heart that we can see. We can see where the impulse is coming from. We can see if there's any delay in conduction, or we can see maybe does this patient have some sort of ischemia hypoxia going on. Does that make sense so far what we've done? Okay, so now, this is my joke to wake people up. So, we're going to interpret an EKG, all right? Without, if there are no ups and downs in life, it means you're dead, right? Because the QRS means that you're pumping blood. And everybody saw flatline means you're dead. So, all right, ACEs. All right, so we're going to start to how to interpret SA node rhythm. So anything that happens in the SA node. So most of these should have what wave? They're coming from the SA node, they should all have P. Coming to the QRS. Okay. So I'm going to start to teach you how to start to read basic EKGs, and this is what this class is about. But we had to set the foundation before we started with this. So we're always going to look at the patients and see what their complaints are, the signs and symptoms, and see what she's complaining. Part of the physical exam, or maybe the general appearance, is Kyle diaphoretic. Is he pale at the same time? So you can have symptomatic bradycardia, or you can have asymptomatic bradycardia. If you're a 6'2" athletic person, and are pretty lean, you're probably going to have a resting heart rate in the 50s, if not maybe 48. So it's okay to walk around with a heart rate that's less than 60. It doesn't mean you have a common patient, you know, with a pacer or giving you drugs to speed your heart rate up. If you're fine, you're confusing, and your blood pressure's fine, we're going to leave that. If you don't have any distress, we're going to leave that. And I'm going to give you a mnemonic to remember if the patient is stable or unstable. So remind me of how to read. Then anything greater than 100, we just call that tachycardia. And then there's a couple different. I never use the number system on top of the rate on top of the EKG machine. I always use triplet method. Now, if it's completely all over the place, then I'll look at the rate number to see what it is. But if it's regular, then I'm always using the triplet method to try to get an idea of where it is. So, this year, the Med 4s are actually learning right now. I talked to Adrian, I think, last week. We're learning the triplet rate already. Oh, you're in that 3. So, what we want to do, you're always with me, that's why I thought for a second. Pretty close. All right, to one of these dark lines, and it just happens this lane's exactly that dark line. So every line over has a numerical value. So what happens is we're going to start with 300, the first one over. Right? If I have another Qrs complex that lands on that first line, automatically I know that that heart rate is 300. Right? Patient's having a bad day if that happens. If I know the next spot it lands at, that's going to be 150. And then so on and so forth. 100, 75, 60, and then 50. Once you get past this line here, it becomes void because you already know the patient is bradycardic. So you need to start maybe pacing the patient or seeing what's going on. But I can at least tell 300, 150, 100, 75, 60, 50. And that's going to give me an idea of where this patient's at. And then I can go ahead and I can look back at the heart rate on the monitor to see what's going on. So let's use this patient for example. This patient lands, here's the first one. So 300, 150, 100, 75, 60. So we're somewhere between, what, 75 and 60, right? The actual heart rate is 70. So that got me where I want to be. Got me right in the right spot. Now also, look here. You have your 6-second hash rate. So, let's count. 1, 2, 3, 4, 5, 6, 7. This one's close, maybe 8. Depending on what those marks are. So you can get a heart rate of deviation of maybe 10. Okay. So, the triplet method gets you closest to where you need to be for the actual heart rate. And it just depends on where those actual hash marks are. But the triplet method looks better. Does everybody understand this triplet method? The first dark line after the first one is 300, then 150, 100, 75, 60, 50. This is the 6 seconds. We already went over this. You count the amount of Qrs complex for the R waves in here, and you multiply that by 10, and that's going to get you how much that is. So in here, we can already see the distance between here and here is not the same distance as here and here. Can everybody see that? It's not regular. Like this spot here is longer than right here. Everybody see that? So that means that the patient's not at a regular interval. So if I wanted to count this, so 1, 2, 3, 4, 5, 6, 7, 8. Right? I'm going to get multiply that by 10. I'm going to get 80. Right? The actual heart rate is 72. And there's no way that I can do the triplet method on this because it's not regular. I would not be able to have a good starting point because it's not regular right there. Does that make sense? So just kind of figure out which one works best. All right, regularity. I just hit on this. We want to know the R-to-R interval across. Is it regular or is it irregular? When you start to learn EKG interpretation, they'll give you calipers. Looks like an old-fashioned compass you had in geometry, and you'll measure. And what you do is you'll take your hand like your calipers like this. You take it here, and you measure here, and then you measure like this, and then you'll map that out for the EKG to see if it's regular. Or you can ruin your eyesight and try to count how many small boxes are in between the two. I'll pass it. But there are 14.5 small boxes, 9 small boxes, 8 small boxes, so on and so forth. And it's pretty evident that the top is regular, the bottom is irregular. You see that? The R-to-Rs are okay. This is the regular rhythm. If I go ahead and I do this all the way across, it doesn't change. Right? And then the box is counted where you need to. This, I think, is pretty evident that it's not regular. All right. So when we start to try to identify atrial fibrillation, atrial fibrillation is recognized by irregularly. And what that means is that it doesn't matter where I look, I can't group anything together. This is regularly irregular. What I mean by that is I can group these together. These are at around 20. All right, 20, 21. I can group these together. These are still around 20. Regularly, irregular, because they're coming in chunks. Does that make sense? So this is just probably what's called a sinus arrhythmia, or arrhythmia. It's regularly irregular. And then when we go to AFib, I'll show you that it's irregularly. Here's AFib. Nowhere in here can I find a couple for more than 3 beats that are the same. These are the same, but nothing else matches them. All right? So that's what's called irregular. All right, then we're going to look at the Qrs complex. Are they less than 3 boxes? And I know it's hard to see, but these are. So we look at that. Sorry, 4 boxes. And these, if you're having this, does anybody know what this rhythm is? VTAC. These are maybe sometimes called tombstones because they indicate death. So if you're in VTAC, you're having a bad thing, you really need to be at the hospital at this point. If not, if somebody has this and they're symptomatic, you just go ahead and light them up with electricity, according to right wherever they are. At one point, I had a patient at a YMCA, like a gym, and he fell off a treadmill, and I saw him, and I had to actually ask, "Were you in the pool?" He's like, "No." He's soaked from head to toe, and he was as blue as Andy's shirt. So I put him on the heart monitor, and I saw this. Well, he's symptomatic, short of breath, he's hypoxic, he's cyanotic. So I lit him up with electricity and converted on That means he has something going on, but I had to intervene. So, all right, and these are obviously abnormal too. Those Qrs complexes are not. This here, this is actually what's called a little run of VTAC. So the ventricles are overpowering the SA node at that point. All right, P waves. Are they present? Do they look alike? And are they there? So you can see, regardless of all of these rhythms, that the arrows are indicating there's a P wave somewhere. So we know that this is coming from the SA node. And then we want to make sure that the measurements are right. And I've kind of talked about this throughout every step. Is the PR interval less than 5 boxes or less than 0.20 seconds? And is there 1 P for every 3? All right. So now we're going to get into some rhythms. And this is what's a normal PR interval. You can see down there it's less than 5 boxes. So that's a normal PR interval. This would be what's called normal sinus rhythm. Normal PR intervals, you can see that between the P wave, where the P wave starts, and where the QRS starts, right here, all right, it's less than 0.20, it's less than 5 boxes. These are abnormal. You can see the P wave starts here. It's elongated, so that means there's something really wrong, maybe the intranodal pathways or something getting to the intranode. All right? This here, this is, believe it or not, this part here that I highlighted on EPR, this is the ST segment. So this guy is having a major heart attack. Right there. So, not only that, but there's some sort of electrical function because it's P wave. PR interval is static. You can see that. Artifact, if somebody moves around, you'll start to say, what the heck is that? All this is from the patient movement. That's it. So I just want to show you that. And then when you have an electrode that's loose, it'll actually depolarize, have a flat line, and come back up, and put it back on. So that's just a loose electrode. All right. So now we're going to fly through some rhythms. The next, is that clock ready? Yep. Okay. This is a normal sinus rhythm, and normally we know it's between 60 to 100. The R to R is irregular, the Qrs complex is narrow, the P wave is upright, and the PR interval should be less than 120. Okay. We're going to get into some dysrhythmias here, all right? So we're going to look at the P waves, we're going to look at the Qrs, and we'll see where it's coming from. Let's see what it is. Okay, sinus tachycardia, we already talked about. It has a P wave, it's got a normal Qrs, and it has a T wave. But the only thing that's wrong with this is the rate. Everything's the same except for the rate. If you count it, 1, 2, 3, 4, multiply that by 10, the heart rate's 40. All right? So, anything less than 60, and everything else is fine. The rate's low, we just call that sinus tachycardia. That's it. Again, you can see 3 different views, and I can see that everything's the same. I can look at my P waves, the same one with ground, and the rest of it, the same one with ground, and the same one. So that's what looking at 3 continuously at the same time does. All right. What would cause sinus tachycardia? Increased parasympathetic tone, drug effects, If they're symptomatic, then we treat them. And I'm going to give you a mnemonic now to remember for the rest of your clinical career. And the mnemonic is going to be CHAP. So if your heart rate's low, what might the first thing you have is start to see some sort of pain? Chest pain. Somebody said it, right? Right, chest pain. Right? The second one, if your heart's not beating, you have a decrease in stroke volume, your ventricles aren't filling up with blood, what's going to happen to your blood pressure? It's going to go down, so you're going to be hypotensive. If my blood pressure's low, my heart rate's low, I'm not getting blood to the brain, am I going to be alert and oriented? No. Probably not. So the next A stands for altered mental status. So I'm not pumping, I'm not moving blood, I have low blood pressure, I'm altered. So if the oxygen's not getting, if the capillaries aren't diffusing, and I can't get the oxygen to the rest of my body, I'm going to be short of breath, or I'm going to have pulmonary edema or something going on. P stands for pulmonary. Anything involving pulmonary. Right? And that can be cyanosis, that can be shortness of breath, that can be low pulse ox. So CHAP. So this mnemonic here will always distinguish, no matter what patient you have in a cardiac patient, whether they're symptomatic or whether they're asymptomatic. Asymptomatic, we usually don't treat. Symptomatic, any of these symptoms, we treat. Does that make sense? Bradycardic algorithm, what do? If we can, if they're symptomatic, then what we'll do is we'll try atropine. Atropine will block any parasympathetic response in the body. It doesn't directly speed up the heart. That's a misconception. It blocks anything that's trying to slow it down in the body. If that doesn't work, then we'll put a pacer pad on them and pace them. We'll give a dopamine infusion, or we can even give them epi. And I'm just highlighting this. I know you guys haven't gone through it yet, but I just want to highlight that. Sinus tachycardia is anything greater than 100. You can see everything is the same, except that it's greater than 100. The rate's just fast. If I wanted to use a triplet method, this one lands here. So 300, 150, 100, and this is just to the right of 150. So it's less than 150, greater than 100, so I know that it's going to be between 100 and 150. It's up there. Yeah, freedom of use, everything is the same. This, pull the all-nighter studying for blocks. You drink enough Red Bull, caffeine, coffee, whatever the case is, it would be tachycardia. All right? Once your heart rate gets above 150, then you have decreased cardiac output because it's just pumping so fast that you're not able to fill up the ventricles. All right? Sinus tachycardia, everything looks the same. I can't group anything really together to say it's regularly irregular or that it's irregularly irregular. It's just off. If I measure these are the same. Then I try to measure this. That's okay. That's okay. And I try to go again. This is off. So various points throughout the EKG, it's not regular at all. So is that just called a sinus arrhythmia? We have a P wave. There's one P wave. There's a QRS, and there's 2 wave. Sinus arrhythmia, just a little irregular here. Does that make sense to you? Okay. And that's the same there. People walk around this all the time. All right, it's no big deal. Normally it doesn't affect anybody. Sinus pause. This is where the SA node, for whatever reason, just fails to fire. And if it happens enough, then you'll actually be implanted with a pacemaker. So PQRST all the way to here. And then the heart's like, oh, I'm tired. I'm not going to fire. And then eventually realizes, hey, I need to fire again. I need to do my job. And then it starts up again. All right? So you have a prolonged. This could be done by the SA node. The SA node, we know it's applied by the majority of people. What artery? Coronary artery. Comes from the right side. And it's coronary artery.
Right
coronary artery. So for 60% of the people, their SA node is applied by the right coronary artery. And then the other percent of the people is applied by the left. So if you're right dominant and you have it, and you start to have atherosclerosis or start to build up a plaque in there, and you start to get lack of blood coming to the SA node or oxygen, your SA node will actually start to misfire and malfunction. So that's what could cause maybe a sinus pause. You get that, they should probably go to the hospital and get checked out. All right. This here, I just want to highlight because it's something that's interesting. I've only seen it once, and I've been practicing since 2008. I want you to look at the P waves. I want you to look at the P waves. The P waves are going to be highlighted by these arrows. And normally the P wave, if it's coming from the same spot, the P wave should be the same. We know that the P wave in the beginning is maybe, let's say, 1.5 boxes. This one here is maybe 3/4 of a box. This one here, they start to fire, then fired again. This one here is taller, right? So what this is called the wandering atrial pacemaker. So what this means is that probably the normal, like this one and the first one, those are being fired, those are being impulsed by the SA node. But what happens is sometimes the atria can get hypoxic or irritated, and they can start to fire too. So that's why your P wave is a little altered, because that ectopic atrial cell is now stimulating the SA node to fire. And so it's just coming from different impulse. And that's why you get different P waves. Right. This here, when we calculate this, we actually have two rates. We have an atrial rate and we have a ventricular rate. This is what's called atrial flutter. Atrial flutter, all right, you'll have some sort of, your SA node will discharge, all right, and then along the atrial, the epinodal pathways, this star here will actually fire again or fire spontaneously. Whatever happens, it's making its own conduction system. So what happens is that'll fire, and it'll maybe fire 3 times before it actually gets down to the AP node. So what we look at is we see here that these are soft, we call them saw teeth. Because if you take a saw and you try to saw wood, that's what it looks like. So the node looks like saw. So when we actually talk about this, we're actually counting the number of, those are called F waves. So there are 3 F waves to every QRS. So if I wanted to correctly see how fast this heart was beating, I count the F waves. So there are 3, 6, 9, 12, 15, 18-ish. Okay. So I have to do 18 times 10, which is 180. All right. And then I have to count the ventricular rate, which is 1, 2, 3, 4, 5, 6, 7. 7. So the P wave, the atrium are firing at 180 times a minute. So that's going to tire out the atrium. That's going to tire out any electrical pathway that's happening. And then we know that the ventricle rate, QRS rather, is 7. So when we say, hey, this patient's in A flutter, we say this patient's in A flutter in a 3-to-1 ratio. So we give a ratio for that. All right? So A flutter, 3-to-1 ratio. Does everybody see that? The F waves 3 times for every QRS. Okay. These are F. Okay. The AV node can't slow them down. The AV node pathways will start. What to do, because the SA node or the atrial route is so high, what you want to do is start off with vagal maneuvers. Those of you who weren't already here when I explained this, does anybody know what a vagal maneuver is? No? Vagal maneuver is, Kyle would describe it as trying to bear down and increase your intracranial pressure. So it's like trying to bear down, right? And what you're doing is you're not really breathing, you're just increasing the interthoracic pressure. By increasing the interthoracic pressure, you change the millimeters of mercury in your baroreceptors. It actually comes back to your heart and actually speeds up your heart because it thinks you're under distress. But afterwards, the baroreceptors have now a new change in the millimeters of mercury, and it'll actually send an impulse back to your heart to tell it to slow down. So we try to naturally have the body do that by doing what's called vagal maneuver. The easiest thing to do is just stick your thumb and put it in your mouth like you're blowing a balloon. So you do this, and you instruct the patient not to let the air out. And you tell them to hold that as long as they can, until the point you're about to pass out. Seriously, and that'll try to slow down the heart naturally. If not, you could do what's called the mammalian dive reflex. We take ice cold water, and put it across the triangle here, and then that's supposed to stimulate the heart to slow down. Andy suggested the carotid sinus massage earlier. The reason we don't rub the carotid is because people don't listen for bruise, and what bruise is the swishing of blood through the artery because of atherosclerosis plaque buildup. So if we hear the swishing of blood, then that means that there's a narrow artery there, which means that they probably have some plaque. If we go and we start to rub the plaque, it's going to break off, go to the brain and cause a stroke. So we fixed your heart attack, but we don't give you a stroke. All right, here's AFib. AFib, and then I'll probably skip over the rest and we'll start to identify some. AFib. Can you guys find anywhere that we can group together? We group anything more than 2 beats together. Not really, right? No, those are different. So we call this irregularly regular because we can't group anything together. Overall, the whole strip is irregular. We knew that. We know we don't have to wait mapping out anything. But then we can't grab anything together, so that's called irregularly irregular. And that is the definition of AFib 100% of the time. So whenever somebody says a patient's an AFib, you need to first, can you discern a P wave? I have no idea which one of these. First thing I told you in 5 steps. You're holding the QRS, the T, the P, the QRS, T, everything else is normal. What do we think it is? Starts with sinus. Dysrhythmia. Right? Because everything else is normal, it just alters every now and then. Right. That's a hard one to pick up on. Alright. No, 6 sinus syndrome will have, it's kind of like sinus